Question 1. A 29-year-old woman on an orthopedic ward complained of pain following surgery to repair a complex fracture of her right ankle. She was given tramadol, and within an hour she became sweaty and agitated. She had a past medical history of bulimia nervosa and was taking fluoxetine 60 mg daily, mirtazapine 30 mg at night, and diazepam 5 mg 3 times daily as required. On examination, her temperature was 38.2 degrees Celsius, her pulse was 102 beats per minute and regular, and her blood pressure was 164/92 mmHg. Neurological examination revealed mydriasis, tremor, hyperreflexia, and increased tone in all limbs but greatest in the lower extremities and clonus induced by rapid dorsiflexion of the left ankle. Additional examination findings included normal skin color and hyperactive bowel sounds. Which medication should not be discontinued? A. Diazepam. B. Metoclopramide. C. Mirtazapine. D. Tramadol. E. Venlafaxine. Answer is A. Diazepam. Summary. The patient is presenting with classical symptoms of serotonin syndrome, a potentially life-threatening syndrome often missed by clinicians. Management should include discontinuing serotonergic drugs, which would include all options apart from diazepam. Indeed, benzodiazepines are recommended for the control of agitation in serotonin syndrome and have been found to improve survival in animal models of serotonin syndrome, perhaps through a blunting of the hyperadrenergic state. It usually occurs in overdoses of serotonergic drugs or when serotonergic medications are used in combination, although it can occur in patients taking therapeutic doses of serotonergic medications. A large number of medications are associated with the serotonin syndrome, including monoamine oxidase inhibitors, selective serotonin reuptake inhibitors, SSRIs, and other antidepressants, opiate analgesics, antiemetics, the mood stabilizers valproate and lithium antihistamines, over-the-counter cough and cold remedy dextromethorphan, and the herbal products tryptophan and St. John's wort. Illicit substances associated with the serotonin syndrome include amphetamines, MDMA, ecstasy, and LSD. Serotonin syndrome is clinical manifestations range from mild to life-threatening. Mild cases involving only restlessness or tremor and sweating may be easily missed. With increasing severity, there is increasing vital sign and neuromuscular abnormalities. In life-threatening cases, patients may have severe hypertension, tachycardia, agitated delirium, convulsions, muscular rigidity, and core temperatures of more than 41.0 degrees Celsius. No investigations confirm the diagnosis, and it must be made on the patient's history and examination. The history should include a full inquiry into all prescribed and over-the-counter medications and illicit substances. The Hunter serotonin toxicity criteria state that in the presence of a serotonergic agent, serotonin syndrome is diagnosed if any of the following are present: tremor and hyperreflexia, spontaneous clonus, increased muscle tone, temperature greater than 38.0 degrees Celsius, and either ocular clonus or inducible clonus. Inducible or ocular clonus, and either agitation or diaphoresis. The differential diagnosis includes anticholinergic poisoning, malignant hyperthermia, and the neuroleptic malignant syndrome, but clinical differences help to differentiate between each condition. Question 2. A 59-year-old woman with chronic obstructive pulmonary disease, COPD, presented to the acute medical unit for the fifth time in 2 months with a history of sudden onset dyspnea and palpitations while out shopping. She admitted to having feelings of intense fear, that she was dying during these attacks, and she was increasingly reluctant to leave her home in case she had another unexpected attack. She did not report an increase in cough, sputum production, or change in sputum color. On examination, she was afebrile and not cyanosed or dyspneic at rest. Her ECG was normal. Her chest X-ray showed no acute changes. She was hoping to once again commence a course of prednisolone and antibiotics to improve her symptoms. What is the most appropriate next step in management? A. Arrange an echocardiogram. B. Discharge without further management. C. The reattribution approach. D. Steroid therapy. E. Treatment with as required diazepam. Answer is C. The reattribution approach. Summary. This patient is describing symptoms suggestive of a panic attack, and a likely history of recurrent uncued panic attacks points to a diagnosis of panic disorder. Patterns of thinking that can predispose some patients with COPD to develop panic disorder include having catastrophic thoughts about somatic symptoms, a heightened perception of symptoms, and a misinterpretation of physical sensations. Once anxiety symptoms develop, a vicious cycle of anxiety symptoms exacerbating COPD symptoms and vice versa can result. Anxiety increases respiratory rate and results in rapid shallow breathing, causing symptoms of hyperventilation including lightheadedness, numbness, tingling sensations, and breathlessness. In patients with COPD, hyperventilation can also induce bronchoconstriction, probably due to exposure of airways to dry cool air, and can additionally predispose patients to developing dynamic hyperinflation, which further exacerbates dyspnea. Comorbid anxiety disorder and COPD lead to significantly reduced quality of life and increased disability, medical treatments, and hospitalization. The recognition of an anxiety disorder is the first step in devising an appropriate ongoing management plan for this patient that avoids further unnecessary investigations, medical interventions, and future similar presentations. Use of the principles of the reattribution approach then provides a useful framework for the treating doctor to explore with the patient the psychological basis of her recent symptoms and how they link to her physical symptoms. In practice, the reattribution approach involves the patient feeling understood, elicit physical symptoms, mood and anxiety symptoms, beliefs held by the patient about their problem, any social problems, relevant physical examination and investigations, broadening the agenda, summarize the physical, psychological, and social findings and negotiate them with the patient. Making the link between physical symptoms, psychological symptoms, and any social problems. Negotiating further treatment, arrange follow-up or treatment of the psychosocial problem or mental disorder. Question 3. A 32-year-old man had been admitted to the ER with a 2-week history of hearing voices and a belief that he was being persecuted. He was very suspicious of all staff and was reluctant to talk to anyone and had been very quiet and guarded. Organic causes had been ruled out, and he was awaiting assessment by the psychiatric services. He became agitated and angry with a member of the nursing staff. Which is the most appropriate initial management approach for his agitation and anger? Call security. B. Confront him with the unacceptability of his behavior. C. Insist he take sedative medication. D. Physical restraint. E. Redirecting the patient towards a calmer personal space. Answer is E. Redirecting the patient towards a calmer personal space. Summary. Disturbed behavior can occur in the context of psychiatric illness, physical illness, substance use, and personality disorder. Psychosis increases the risk of violence compared with the general population, and substance use substantially increases the risk. The initial approach to disturbed and agitated behavior should be psychological and behavioral de-escalation approaches, which are techniques to diffuse or talk down disruptive behaviors and to prevent violence. Verbal de-escalation includes avoiding confrontation, redirecting the patient towards a calmer personal space, observing for signs and symptoms of anger and agitation, approaching the patient in a calm, controlled manner, giving the patient choices. Maintaining patient dignity. Observation also helps to prevent violence, watching the patient attentively while avoiding making them feel under surveillance. In this way, early signs of agitation can be identified and diffused. It may be necessary to move the patient to a more appropriate environment. Urgent sedation or rapid tranquilization does not have a strong evidence base, is not without risks, and should be viewed as a treatment of last resort. Oral sedatives should be offered first, usually benzodiazepines, to avoid the risks associated with combining antipsychotics if intramuscular, IM, antipsychotic medication is subsequently required. Concomitant use of 2 or more antipsychotics increases the risk of QTc prolongation common to all antipsychotics, especially where disturbed behavior predisposes patient to developing cardiac arrhythmias. IM treatment options include lorazepam, midazolam, promethazine, olanzapine, aripiprazole, and haloperidol. Haloperidol should be considered last due to high rates of extrapyramidal side effects, including acute dystonic reactions in 5% of cases, and its QTc prolongation effects. A pretreatment ECG is recommended. Studies suggest IM olanzapine is more effective than haloperidol, and that both are more effective than aripiprazole.